In this section of the review, we will begin our discussion of antimicrobials and focus in on cell wall inhibitors. Generally speaking, we have at our disposal both naturally occurring and synthetic antimicrobial agents that disrupt various parts of the bacteria. These include drugs that block cell wall synthesis by inhibition of peptidoglycan cross-linking, such as penicillin, ampicillin, Ticarcillin, piperacillin, Imipenem, Aztreonam, and the Cephalosporins. We have drugs that block peptidoglycan synthesis, such as Bacteriostatic and Vancomycin. Some disrupt bacterial cell membranes, like polymyxins. Others block nucleotide synthesis, like the sulfonamides and trimethoprim. Continuing on, we have drugs that block DNA topoisomerases, like fluoroquinolones, drugs that block mRNA synthesis, like rifampin, drugs that block protein synthesis at the 50S ribosomal subunit, including chloramphenicol, macrolides, clindamycin, streptogramids, like quinupristin and dalfapristin, and linezolid. We also have drugs that block protein synthesis at the 30S ribosomal subunit, like aminoglycosides and tetracyclines. Let's mention for a minute the difference between bacteriostatic and bactericidal antibiotics. As the name suggests, static are used to slow down the growth of bacteria, and cidal are used to kill bacteria. Clinically speaking, we use bactericidal whenever we can, and use bacteriostatic when they are called for in certain situations. But remember that bacteriostatic cannot kill, they can only slow down the growth. The bacteriostatic microbicidal agents include erythromycin, clindamycin, sulfamethoxazole, trimethoprim, tetracyclines, and chloramphenicol. You can remember these by the mnemonic we're ecstatic about bacteriostatic. So in ecstatic we have E, C, S, T, T, and C. Erythro, clinda, sulfamethoxazole, trimethoprim, tetracyclines, and chloramphenicol. For the bactericidal drugs, remember these include vancomycin, fluoroquinolones, penicillins, aminoglycosides, cephalosporins, and metronidazole. You can remember these with the mnemonic very finely proficient at cell murder, VFPACM, vanc, fluoroquinolones, penicillin, aminoglycosides, cephalosporins, metronidazole. Let's talk about the penicillins, specifically penicillin, the very first generation. It comes in two forms, penicillin G, which is the IV form, and penicillin V, which is the oral form. This is the prototype of the beta-lactam antibiotics. Its mechanism of killing is to bind penicillin-binding proteins, block transpeptidase cross-linking of the cell wall, and activate autolytic enzymes. Clinically, we use penicillins as bactericidal agents for gram-positive cocci, gram-positive rods, some gram-negative cocci, and spirochetes. Penicillin, the first generation, is not penicillinase-resistant. Toxicities for penicillin include hypersensitivity reactions as well as rare hemolytic anemia. The second generation of penicillins are the penicillinase-resistant penicillins, including methicillin, nafcillin, and dicloxacillin. The mechanism of action of these drugs is the same as penicillin. They also have the same narrow spectrum of activity that penicillin has. They are, however, penicillinase-resistant because of a bulkier R group. Their clinical use includes the treatment of Staph aureus, except for MRSA, which is resistant not because of penicillinase, but because of altered penicillin-binding protein target sites. So remember, use NAF for staph. The toxicity of these drugs includes hypersensitivity reactions, and for methicillin specifically, it can cause interstitial nephritis. The next generation of penicillins are the aminopenicillins, which include ampicillin and amoxicillin. Their mechanism, again, is the same as penicillin. They have a wider spectrum of activity but are penicillinase sensitive. We oftentimes combine these drugs with clavulanic acid, which is a penicillinase inhibitor, to enhance the spectrum. Amoxicillin has greater oral bioavailability than ampicillin, so keep your O's together there. Amoxicillin, oral bioavailability. You can also remember that ampicillin and amoxicillin are amped up penicillins. Clinical use of these drugs has an extended spectrum compared to the previous penicillins. It includes certain gram-positive bacteria and gram-negative rods, like Haemophilus, E. coli, Listeria monocytogenes, Proteus mirabilis, Salmonella, and enterococci. You can remember this coverage by remembering that ampicillin and amoxicillin helps kill enterococci. So for helps, you have H. Haemophilus, E. coli, L. Listeria, P. Proteus, S. Salmonella, and enterococci. Toxicity to these agents includes hypersensitivity reactions, an ampicillin rash, and the development of pseudomembranous colitis. The next generation of penicillins are the antipseudomonals, including Ticarcillin, carbenicillin, and piperacillin. They have the same mechanism of action again as penicillin, but have an extended spectrum to include Pseudomonas species and gram-negative rods. They are susceptible to penicillinase, so again they are used with clavulanic acid, which is a beta-lactamase inhibitor. Remember these by TCP, takes care of Pseudomonas, Ticarcillin, carbenicillin, piperacillin. The toxicity for these includes hypersensitivity reactions.
Let's talk about beta-lactamase inhibitors for a second. These include clavulanic acid, sulbactam, tazobactam as well. These are often added to penicillin antibiotics to protect the antibiotic from destruction by beta-lactamase or penicillinase. You can remember these by the mnemonic CAST, clavulanic acid, Ca, sulbactam, S, and tazobactam, T. When we combine these with the penicillins, we come up with our newer or combined penicillins like Zosyn or Unicin.
Moving off of the penicillins, let's talk about cephalosporins. Cephalosporins are beta-lactam drugs that inhibit cell wall synthesis but are less susceptible to penicillinases. They, like the penicillins, are bactericidal. The first generation cephalosporins include cefazolin and cephalexin. Their spectrum of activity includes gram-positive cocci, Proteus mirabilis, E. coli, and Klebsiella pneumoniae. So for first generation, remember gram-positive cocci and the mnemonic PEC, Proteus, E. coli, and Klebsiella. Second generation cephalosporins include cefoxitin, cefaclor, and cefuroxime. Their spectrum includes gram-positive cocci, as well as Haemophilus influenzae, Enterobacter aerogenes, Neisseria species, Proteus mirabilis, E. coli, Klebsiella pneumoniae, and Serratia marcescens. So the mnemonic for the second generation cephalosporins, apart from the gram-positive cocci, is HENPEX, Haemophilus, Enterobacter, Neisseria, Proteus, E. coli, Klebsiella, and Serratia. The third generation cephalosporins include ceftriaxone, cefotaxime, and ceftazidime. These are used for serious gram-negative infections resistant to other beta-lactams. We use these for meningitis. Most of them penetrate the blood-brain barrier well. Examples for use include ceftazidime for Pseudomonas and ceftriaxone for gonorrhea. The fourth generation cephalosporin is cefepime. It has increased activity against Pseudomonas and gram-positive organisms. The toxicity for cephalosporins include hypersensitivity reactions. There is a cross-hypersensitivity with penicillins that occurs in 5 to 10% of patients. These drugs also increase nephrotoxicity of aminoglycosides. There is also a disulfiram-like reaction with ethanol in cephalosporins that contain the methylthiotetrazole group like cefamandol. Aztreonam is another beta-lactam. It's a monobactam resistant to beta-lactamases. It inhibits cell wall synthesis by binding to PVP3. It's synergistic with aminoglycosides, and there's no cross-allergenicity with penicillins. It's effective against gram-negative rods like Klebsiella, Pseudomonas, and Serratia. There's no activity against gram-positive or anaerobes. For penicillin-allergic patients and those with renal insufficiency who cannot tolerate aminoglycosides, Aztreonam is a good choice. It's usually non-toxic. There's occasional GI upset with use. There's, again, no cross-sensitivity with penicillins or cephalosporins. Imipenem and meropenem are another group of cell wall inhibitors. Imipenem is a broad-spectrum beta-lactamase-resistant carbapenem. It's always administered with cilastatin, which is an inhibitor of renal dihydropeptidase 1. This is included to decrease inactivation in the renal tubules. So remember, with imipenem, the kill is lastin with cilastatin. We use these drugs for gram-positive cocci and gram-negative rods as well as anaerobes. It is the drug of choice for Enterobacter. The significant side effects of these drugs limit use to life-threatening infections or after other drugs have failed. Meropenem, however, does have reduced risk of seizures and is stable to dihydropeptidase 1. The toxicities for these drugs include GI distress, skin rash, and CNS toxicity, including seizures at high plasma levels. Vancomycin is another drug. It inhibits cell wall mucopeptide formation by binding D-ala-D-ala portions of the cell wall precursors. It is bactericidal. Its clinical use is used for serious gram-positive multi-drug-resistant organisms, including Staph aureus and Clostridium difficile, when pseudomembranous colitis is a problem. Its toxicity includes nephrotoxicity, ototoxicity, and thrombophlebitis with diffuse flushing, known as red man syndrome. This red man syndrome can largely be prevented by pretreatment with antihistamines and a slow infusion rate. Generally, it's well tolerated and does not have many problems. You can use that mnemonic NOT to remember nephrotoxicity, ototoxicity, and thrombophlebitis. The resistance to vancomycin occurs with amino acid change of D-ala-D-ala to D-ala-D-lac. And that concludes this section of the lecture.